You want to mute? Wait.
I think we are live now. Yes, it is showing webinar is now streaming live on YouTube. Yeah.
Okay, sir. Okay, sir. So now I have to intimate to the all doctors, sir. Link is okay.
Yeah, Mutaiya ji. Yeah, I think Amrish ji, we are good to go.
Sir, people are replying. Still server it's error only.
Okay, still it is showing error. Okay.
Actually, Dr. Arul reply. Cardiology is send active link.
Okay. So, Amrish ji, we are still getting the same response from the team. We are getting the response that still they are not live.
Just wait, we are just going live. Just wait.
Yeah, silent.
Sir, now we are live. You can proceed ahead.
Okay, sir.
Mutaiya ji, I'll just confirm you. I'm just on the link. Yeah.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Now starting response, sir.
Okay. So we can start at 1 minute, 12:10. We can start.
Okay, sir. Okay, sir.
Yeah. Yes, we can start.
Okay, sir. I have to go, sir.
Yeah, Mutaiya ji, we can start.
Okay, sir. Sir, welcome, sir. Dr. Natarajan, sir. I glad to introduce Dr. Natarajan, sir. He is a more than 40 years experience in treating heart-related ailment in his patients, and he received best outstanding student award in CMC Coimbatore, and sir is recipient of the inaugural Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University. And also Dr. Manan and Dr. Sarojini Raman medals. Sir Edmund Chalk Memorial Prize in General Medicine also, and past president of IMA Coimbatore branch and Coimbatore and Tamil Nadu chapter of CSI Indian College of Cardiology. Lifetime achievement of our IMA Coimbatore branch and Indian Association of Clinical Cardiology of Tamil Nadu chapter. And Dr. is chairman of 12th National Conference of Indian College of Cardiology and has done extensive work for research in hypertension and ACS and clarity of registry. Thanks to welcome for this platform, sir. Thank you, sir.
Thank you. Share screen.
So you can share your screen, right?
Morning, friends. Amid our attention to a pandemic of corona, we should not forget yet another pandemic which was prevailing for the last 1 decade in India, namely the cardiovascular diseases. As you all know, cardiovascular diseases contribute to the major morbidity and mortality in developing countries like India, and that is one of the major problems which we have to control. Among the cardiovascular diseases, coronary artery disease is one of the major problems which we face. Today we are going to discuss about a very important molecule, rivaroxaban, in managing cardiovascular diseases. As you all know, the role of platelet and clotting factors in evolution of acute coronary syndromes has been there for many decades. And we have been trying to control the pathogenetic factors in improving the outcome. Though initially heparin was used as the only therapy for acute coronary syndrome, the introduction of antiplatelet agents overshadowed the role of anticoagulants. Anticoagulants were mainly confined to use of mechanical prosthetic valves, atrial fibrillation, and venous thrombosis. And as you all know, the oral anticoagulants have a very tough journey. We introduced decumarol and warfarin in the middle of last century. For next 50 to 60 years, we have been struggling to have another agent, purely because we had a lot of problems with the warfarin group of drugs. In 2008, we had the introduction of dabigatran, rivaroxaban, followed by apixaban and edoxaban. So we have 4 agents whom we call as NOACs, novel oral anticoagulant agents, or direct oral anticoagulant agents. Of them, I'm going to discuss in detail about one molecule, namely rivaroxaban, which has got many features which are outstanding compared to other NOACs. As you all know, the oral anticoagulation has been useful for prevention and treatment of deep vein thrombosis and pulmonary embolism. That's on the venous side. On the arterial side, we have been using it for non-valvular AF, much more important for mechanical heart valves, and also for LV thrombus, atrial thrombus, and whenever there had been an embolic stroke. And our main agent of controlling the disease with respect to oral anticoagulation has been the vitamin K antagonist. As I said, for nearly 50 to 60 years, we have been managing only with vitamin K antagonists, which had a lot of problems. They had a very narrow therapeutic range because, as you all know, I know it to be between 2 to 3. And that needs constant monitoring and dose adjustments, and which adds on to the cost of the patient. And not only that, multiple drug interactions with food, the slow onset and the slow offset. And much more important, when you initiate vitamin K antagonist therapy, initially it affects the natural anticoagulants, protein C and S, before it affects the clotting factors, thereby causing what we have the warfarin skin necrosis. So we have to give heparin in the initial few days before the full action of warfarin is to come into play. And again, the much worsened, much feared intracranial hemorrhage. And again, genetic polymorphism, the individual dose variations due to the metabolizing drugs, the metabolism involved in the drug, namely the cytochrome P system, which is a large genetic polymorphism. So we have slow metabolizers and fast metabolizers requiring at one extreme very low dosage and other extreme very high dosage. So we have been finding it very difficult to give the vitamin K antagonists all these years as one of our effective therapies. Now then came from the introduction of dabigatran and rivaroxaban, the group of agents whom we as NOACs. Now NOACs can be broadly classified as direct thrombin inhibitors, wherein we have a dabigatran, and other is a factor 10A inhibitors, under which you have rivaroxaban, apixaban, and edoxaban. As you all know, the dabigatran was introduced approved by the FDA in 2010. Dabigatran, rivaroxaban in 2011, 2012, apixaban and edoxaban 2015. So we have 4 NOACs at present available. Of them, I'm going to discuss in detail about rivaroxaban today, which is a factor 10A inhibitor. Now, factor 10A, as you all know, is a common pathway for both intrinsic and extrinsic pathway of coagulation. So that's the final pathway which activates prothrombin to thrombin, and thrombin in turn acts on fibrinogen and converts it to fibrin. Now, we have different wide spectrum of use of oral anticoagulants. Chronic ischemic syndromes, acute coronary syndrome, post-MI, peripheral arterial disease, atrial fibrillation, and then a combination of atrial fibrillation with antiplatelet usage and atrial fibrillation in patients with renal failure. Now, this slide shows you the pharmacological characteristics of the various oral anticoagulants, starting from warfarin, dabigatran, apixaban, rivaroxaban, and edoxaban. As you see here, all the bands, apixaban, rivaroxaban, and edoxaban, have a very good high protein binding, like warfarin. And the greatest advantage of rivaroxaban is that it can be given once a day. And coming to metabolism, 1/3 is excreted unchanged in the urine, and 2/3 is hepatically metabolized, and part of it comes in the urine and part of it comes in the fecal excretion. Now, I said earlier, the greatest problem with warfarin was the interaction with food and drugs. Though there is no significant food interaction with the rivaroxaban, we do have to remember a few drug interactions which are involving the cytochrome system, or cytochrome 450 system, which is involved in drug metabolism, and also the the P-glycoproteins, which are also involved in drug metabolism. Now, what do we need anticoagulants for cardiovascular prevention? Because all these years we've been stressing more on antiplatelets rather than anticoagulants. Now, in chronic coronary syndrome, which we thought that is all thrombotic disease, atherosclerotic disease, what's the role of an antithrombotic or anticoagulant? Now, in the subclinical phase, the disease is not going to be well treated. Once the diagnosis is made or patient undergoes revascularization, there's always a chance of an acute episode being superadded on a chronic coronary syndrome, namely ACS. We also have another group of patients who have undergone revascularization. Now, if you look at the natural history curve, the best is with the revascularization, whereas a higher risk is associated with inefficiently controlled risk factors, suboptimal lifestyle modification, and failure to have adequate medical therapy, and also a large area of risk involved in myocardial ischemia. Now, the lesions which have a high myocardial damage. So, whenever a patient has got well-controlled risk factors with lifestyle modification and well-controlled drug therapy using statins, antiplatelets, and ACE inhibitors, and also have appropriate revascularization, the natural history is well-controlled, as opposed to the higher risk of these people who have insufficiently controlled risk factors, suboptimal lifestyle modification, and lack of compliance in medical therapy, and have lesions which have a very high myocardial risk. Now, they are the high-risk patients who have a chance for superimposed episodes of acute coronary syndrome. As you see here, the Fourier incidence of MACE in patients with chronic ischemic syndrome can be as much as 20% over 4 years. So in spite of guideline-recommended therapy, patients with previous ischemic events are at a higher risk. As you see here, they are the ones who have a high risk. So anybody who is present with ischemic episode, even though you think the disease is chronic and stable, he has a very high incidence for recurrence of the event within 4 years. So we need a holistic approach for vascular protection. What does it include? So we have to control the cardiovascular risk factors to limit the atherosclerotic progression and stabilize the active plaques, which includes lifestyle change and medical therapies. Lifestyle change includes smoking cessation, regular exercise, appropriate diet, weight management, and psychosocial support. Whereas medical therapy includes statins, ACE inhibitors or ARB, good diabetic control, and next phase important vascular protection is to prevent occurrence of blood clots over active plaques. And there comes our antiplatelet therapy. Usually we give single antiplatelet in chronic stable angina, whereas when it becomes acute, we need to have a dual antiplatelet therapy. Now, why think about an anticoagulant in this situation? We have to remember that thrombin is the most potent stimulator of platelets. And our current antiplatelet regimen of aspirin and thienopyridines do not block the thrombin receptor on the platelets, except Varaxapac. And blocking active factor 10, it inhibits the thrombin generation both from intrinsic and extrinsic coagulation pathway, because that's the final common pathway. And over a period of time, following an acute coronary event, the platelet activation diminishes, whereas thrombin generation continues to be elevated. So, as you see here, because the activated thrombin generation is a good role for antithrombotic, especially in the form of a oral anticoagulation with rivaroxaban. Rivaroxaban affects not only fibril formation, but also platelet activation through thrombin. As I said, the current antiplatelet regimen does not prevent thrombin-activated platelet activation. So, in ACS management, guidelines recommend DAPT, but we have to also consider in high-risk patients, wherever you feel, we will discuss who is a high-risk patient and who is so you have to select the right patient and add oral anticoagulation in the form of rivaroxaban, which will contribute to a significant reduction in cardiovascular death and all-cause mortality. Who is the right patient? Patients increase ischemic risk. And not only that, they should have decreased bleeding risk. So your Your approach to control increased ischemic risk should not be at the expense of increased bleeding risk. So you have to choose patients with no history of stroke or TIA, no risk of major bleeding, especially GI tract, and have a good creatinine clearance of more than 30 ml per minute, and they are not already on anticoagulation. For all the patients with increased risk, elevated cardiac biomarkers, multivessel disease, diabetes, hypercholesterolemia. Now, we also consider people without increased bleeding risk. That is, as I said earlier, no earlier cerebrovascular episodes, no risk of major bleeding, no active major bleeding, who are not obese, whose creatinine clearance is well above 60 ml per minute and have no anemia. So it's a question of weighing the ischemic risk versus bleeding risk. So to weighing the individual patient risk for ischemic and bleeding events, you can, in patients with high ischemic risk with low bleeding risk, a combination of rivaroxaban at a low dose of 2.5 milligram twice a day, along with dual antiplatelets for 12 months or more, will be one way of improving the secondary prophylaxis. This was shown by the ATLAS trial, which was done on patients with recent acute coronary syndrome. The rivaroxaban vascular dose reduced the cardiovascular events and death in patients with ACS, as you see here. There is a 16% reduction in MACE, and 34% reduction in cardiovascular death, and 32% reduction in all-cause death. And the numbers needed to treat varied around 60 to 70. By showing that it causes a significant effect on patients' long-term survival after an acute coronary syndrome when you add rivaroxaban to the dual antiplatelet regimen. So rivaroxaban 2.5 milligram twice a day, co-administered with aspirin alone or with thienopyridines, is indicated in patients with acute coronary syndrome with elevated cardiac biomarkers and who have a high risk for ischemic events and have a low risk for bleeding. So that should be our next approach. As you see here, we have different therapies for secondary prevention following an acute coronary event. One is a lipid lowering. As you all know, each millimole reduction in LDL causes 21% reduction in MACE, 15% reduction in stroke, 25% reduction in MI, and 9% reduction in death. Same way for each 10 millimeters systolic BP reduction, you have 20% reduction in MACE, 27% reduction in stroke, 17% in MACE, MI, and 13% reduction in death. Same way, the HOPE trial has shown that adequate, appropriate ACE inhibition causes reduction of nearly 20% in MACE, stroke, and cardiovascular death. Once rivaroxaban is added, you see that there's a good reduction of MACE, stroke nearly 40%, MI around 20%, and overall death about 20%. So you have one more armamentarium, one more agent in your armamentarium against acute coronary syndrome. In addition to lipid lowering, BP lowering, ACE inhibition, you would also consider rivaroxaban, where you have a high chance of ischemic risk with a low bleeding risk. So it's one more, this is a fourth step in vascular protection as a secondary prevention. So this slide again shows you the various trials which have formulated the guidelines. As you all know, the CAPRI trial, which showed the usefulness of clopidogrel, 9% risk reduction. Then dual therapy versus single therapy with aspirin, again, there was a 17% risk reduction. Then the Pegasus trial, which showed the use of ticagrelor with aspirin versus aspirin, which showed a 16% relative risk reduction in MACE. Varipaxar, which you all know is one of the thrombin receptor inhibitors in antiplatelet. Again, when given along with the aspirin plus or minus thienopyridine caused a 13% relative risk reduction, but at a risk of 1.7, nearly twice the risk of severe bleeding. And rivaroxaban showed a 24% reduction in MACE, which is the highest among the various measures, but there was an increase in bleeding risk by 60%. But there was a reduction in all-cause mortality, which was not seen in any other trial. So there's a good scope for considering rivaroxaban in patients with acute coronary syndrome with a high ischemic risk with a low bleeding risk. And this is shown as the COMPASS trial, where rivaroxaban 2.5 milligram twice a day in addition to 100 milligram of aspirin was compared to aspirin alone or rivaroxaban 5 milligram twice a day alone. So nearly 28,000 patients were included in this trial in 300 centers. It was a double-dummy, double-blind trial, which had an initial run-in period of 1 month and followed by 1 month of washout period. The study was terminated early because of very high significant results in the experimental arm following 23 months of trial. The inclusion components were any previous MI, multivessel coronary artery disease or multivessel revascularization, plus one or more of the following: age above 65 years or age less than 65 years with involvement of 2 vascular beds or 2 additional risk factors, which included smoking, diabetes, renal dysfunction, and heart failure and non-lacunar ischemic stroke. So any of these components were the inclusion criteria. Patients with recent stroke, hemorrhagic or non-hemorrhagic, severe heart failure, people who require dual antiplatelet therapy like recent ACS for other reasons, or anybody with a severe renal dysfunction, a GFR of less than 15 ml, they are excluded. So this trial comprised people with coronary artery disease with a high risk. And this group, rivaroxaban twice a day with aspirin alone, or rivaroxaban alone, was compared as 3 different groups. And the study results showed that there's a significant reduction in MACE, MI, stroke, and cardiovascular death whenever rivaroxaban and aspirin were combined together, compared to either agent alone. So either aspirin alone or rivaroxaban 5 milligram twice a day alone was not as efficacious as rivaroxaban 2.5 milligram twice a day with aspirin. But of course, there was 1.6 times more major bleeding, but that it did not include fatal or non-fatal bleeding. So in chronic cardiovascular disease, that is so-called chronic ischemic syndrome, who derives the greatest benefit from the COMPASS regimen? So you have more and more high risk, you have more and more benefits. As you see here, patients with the diabetes, renal impairment, heart failure, peripheral vascular disease, they were the ones who benefited most, because for every 1,000 patients, when the highest group had 60 patients benefited over 30 months, whereas the overall population, there is a 23 to 23 people per every 1,000 patients where MACE events are prevented, either MACE or acute limb ischemia or amputation. So this shows that more the higher risk for ischemic events, better the outcome of using rivaroxaban. I think that should be the carry-home message, that in high-risk ischemic patients, when the bleeding risk is not significant, there's a good scope for including oral anticoagulation in the form of rivaroxaban in low dose. Same way, I see more and more risk factors give more and more protection compared to 0 risk factor, 1 risk factor, 2 risk factor, 3, as you see here. Not really, the separation of the lines are different. They occurs much earlier. The separation occurs much early, so that the benefits start early and become more and more significant as the follow-up becomes more. That is why In 2019 European guidelines for chronic ischemic syndromes, in addition to now, the high ischemic events or high ischemic risk was defined as diffuse multivessel coronary artery disease with at least one of the following: either diabetes, recurrent MI, peripheral arterial disease, or CKD. Moderate ischemic load, at least one of the following: multivessel or diffuse disease, diabetes, recurrent MI, peripheral arterial disease, heart failure, and CKD with 15 to 60 ml creatinine clearance of GFR, creatinine clearance of 15 to 60 ml per minute. And they recommended using 2 antithrombotic drugs. Now, what is the COMPASS trial impact in Indian population? Now, there's a critical analysis done by Kerker et al. It shows that patients less than 65 have a much greater reduction in MACE whenever rivaroxaban is added, the COMPASS regimen is added. So the critical analysis of COMPASS trial showed that younger age group appeared to derive greater benefit from rivaroxaban aspirin combination, as seen with the number needed to treat. As see, a number needed to treat is less than 50 in younger age group as opposed to 91 in people above 65. So the decision to prescribe rivaroxaban in India to patients less than 65 years can be considered as an option, as the disease occurs a decade earlier in India. As you all know, the coronary artery disease occurs in Southeast Asian population 10 to 15 years earlier than the Western population. So I think when Western countries think 75 as a cutoff point for a very severe elderly, I think here 65, we advance it by 10 years and consider 65 as an age group. The benefits may not be much, or probably the bleeding risk may be more. Whereas the ischemic risk and benefits are more with younger age group. As see here, the COMPASS regimen is the first long-term antithrombotic therapy to reduce the mortality. Whenever in this COMPASS regimen, as you see here, there's a 24% reduction in MACE, 42% reduction in stroke, 14% reduction in MI, and as overall death reduction by 18%, with a bleeding risk increased by 70%. This is as opposed to all the other trials, CAPRI trial, Charisma trial, Pegasus trial, where different antiplatelets have been used in singly or in combination. Now, a few words about peripheral arterial disease. As you see here, the coronary artery disease has a significant overlap with the peripheral arterial disease. And a significant number of people have both. So here, peripheral artery disease, as you all know, is one of the high risk factors for coronary artery disease. So atherothrombosis is a polyvascular disease with substantial patient overlap between coronary artery disease and peripheral vascular disease, as has been shown by REACH registry, which included nearly 67,000 patients. 25% of patients with coronary artery disease had disease in other vascular beds, either cerebrovascular or peripheral vascular. 61% of patients with peripheral vascular disease had other vascular diseases and had 2 to 3-fold increase in risk of stroke and 4 to 5-fold, 4-fold increase in risk of fatal MI. So that by showing that the peripheral arterial disease is a high risk group, which has a high incidence of MI and stroke, nearly 3 to 4%, 3 to 4 times. Now, what do we have today to treat peripheral arterial disease patients? We have drugs methods to improve the symptoms and also methods to reduce the cardiovascular risk. Symptom improves by exercise training, silastazole, stent placement, or surgical revascularization. Whereas cardiovascular risk reduction includes statins to reduce lipids, ACE inhibitors, diabetes, most important, smoking cessation, and antiplatelet drugs. So drug point of view, you have lipid-lowering drugs, ACE inhibitors, diabetic regimen, and antiplatelets. Now we have led various trials to show their use. As you all know, the Capri subgroup, where clopidogrel was tried against aspirin, there's a 24% reduction in MACE. Whereas when ticagrelor versus clopidogrel, there was no reduction in MACE. Clopidogrel plus aspirin versus aspirin, there's a charisma subgroup. Again, there was a 17% reduction in MACE, with a 60% increase in moderate bleeding. And how about patients who have undergone revascularization in peripheral arterial disease? Again, they are highly vulnerable for major events. Major amputation and limb revascularization occur in almost 40% of individuals over 6 years. And they also have MI and stroke incidents. So there's a 4% risk of acute limb loss on long-term treatment, or long-term follow-up. So in patients of acute limb ischemia, what are the outcomes? Nearly 1/5 have a major amputation, 1/3 have a prolonged ICU stay, and 3 out of 4 have a major surgery. And outcomes after hospitalization is poor, with 15% disabled or dead. So such is the outcome, long-term outcome in patients with acute limb ischemia. So despite the high risk, there is no proven antithrombotic strategy that has reduced the major adverse limb and cardiovascular events in peripheral interventions for ischemia. As you see here, when you have a DAP regimen, the proportion, even number of people have less events, keeps on decreasing over a period of time. It comes almost to 60% by second year itself. And when you have a full intensity oral anticoagulation, the risk of hemorrhagic stroke becomes more. So what you try to achieve by reducing the ischemia is at the cost of increased bleeding. Whereas the compress regimen showed a new option. The platelet activation can be inhibited by aspirin as well as by rivaroxaban, because as you all know, thrombin is a potent stimulator of platelet aggregation. So in this, the rivaroxaban not only causes factor Xa inhibition, preventing thrombin generation, it also decreases the platelet activation in addition to the antiplatelet effect of aspirin. So rivaroxaban and aspirin synergistically target the essential components of atherothrombosis. So the dual pathway inhibition with rivaroxaban, low dose rivaroxaban, that is 2.5 milligram twice a day with aspirin, reduce the MACE by 28% and limb events by 46% versus aspirin. As you see here, the slide shows you when you add a rivaroxaban to aspirin regimen, the amount of reduction in MACE and limb ischemia is very high. So the combination of rivaroxaban with aspirin is the only therapeutic option which has reduced the cardiovascular events and limb events, including amputation in patients with peripheral arterial disease, versus all other different regimens available. As you see here, clopidogrel versus aspirin in Capri subgroup, the reduction of MACE was though 24%. Limb outcomes are not described. Same way, ticagrelor versus clopidogrel in Euclid, there was no reduction in MACE. Clopidogrel plus aspirin versus aspirin in Charisma trial, MACE reduction by 17%. Whereas rivaroxaban aspirin combination versus aspirin in peripheral arterial disease, so-called the COMPASS subgroup, nearly 30% reduction in MACE and reduction in limb ischemia by 50% and major reduction in amputation by 70%. Of course, there was 60% excess major bleeding. That is why new guideline recommendations of European Society for Vascular Surgery as well as Vascular Medicine includes a combined therapy of aspirin with rivaroxaban 2.5 milligram twice a day should be considered in peripheral artery patients with a high risk of ischemia with low risk of bleeding and do not have any contraindications. So the various guidelines all highlight the adding the low dose rivaroxaban. So among the various secondary prevention therapies, rivaroxaban with aspirin is again one step forward. So it reduces the MACE by 24%, death by 18%, stroke by 42%, MI by 14%, as opposed to the various other agents like glyphosins, PCSK9 inhibitors, triglyceride lowering, and anti-inflammatory colchicine. Colchicine, again, as you all know, has shown some 30% reduction in events, but with an excess non-cardiovascular death, which is also to be considered. So in symptomatic peripheral artery disease patients requiring revascularization, as has been seen, when you add rivaroxaban, there's a reduction in acute limb ischemia, major amputations, myocardial infarction, ischemic stroke, and cardiovascular death over a period of 36 months. And the separation starts as early as 6 months. As you see here, the number needed to treat is around 40 to 50. So that we're showing a significant impact on the natural course of the disease. So any symptomatic peripheral arterial patient who has undergone revascularization, I think we have to also consider low-dose rivaroxaban. The Voyager PAD study has shown the secondary outcomes. As you see here, there's a significant reduction whenever rivaroxaban added to the regimen in different things: MI, ischemic stroke, vascularization, so hospitalization for vascular events, and including venous thromboembolism. So Voyager PAD is the only large randomized study to demonstrate significant cardiovascular and limb benefit after peripheral revascularization. As opposed to many other trials, as you see here, the Voyager shows basal bleeding risk of only increased by only 40%, whereas all other parameters are showing very good improvement, statistically significant improvement. So from acute intervention to long-term secondary prevention, rivaroxaban 2.5 milligram twice a day with aspirin reduces the risk of major adverse limb and cardiovascular outcomes: less MACE, less limb events, less amputation, less unplanned revascularization, less and vascular hospitalization for vascular disease. So rivaroxaban can be used in acute as well as a chronic phase of revascularization in limb ischemia. So the Voyager PAD and COMPASS trials have shown its utility both in the chronic phase and the acute phase. So when do you start the dual mode of management? Post-intervention, once hemostasis is achieved within 10 days. And COMPASS trial in the chronic phase, whoever has a high MACE risk, concomitant coronary artery disease, diabetes, GFR of 15 to 60, heart failure, smokers. And also who have a high limb risk, namely pre-revascularization or amputation, chronic limb ischemia, and smokers. So these are the patients who have been given the COMPASS regimen for better secondary prevention. So in patients with peripheral arterial disease, for a better vascular antithrombotic protection, high-risk patients get the most benefit. Who are the high-risk patients? 70 years old with coronary artery disease, worsening symptoms, diabetes, intermittent claudication, following revascularization or amputation, or who are an ankle brachial index of less than 0.9. So these are various high-risk groups who are in rivaroxaban can be considered in addition to aspirin. Now, one more group of people who benefit will be the people with atrial fibrillation. As you all know, atrial fibrillation is an initial indication for chronic oral anticoagulation. Now, when acute coronary syndrome coexists with atrial fibrillation, nearly it is supposed to have 2 to 20% of patients with ACS have atrial fibrillation. We have a good indication for using a NOAC. And stroke prevention is very important in atrial fibrillation. Now, except in mechanical heart valves or patients with atrial fibrillation who have a moderate or severe mitral stenosis, NOAC can be indicated in other situations. First, you need to have a CHA2DS2-VASc score estimation. If a score is 1, though earlier antiplatelets were recommended, OSA also should be considered. But 2 and more is a definite indication for oral anticoagulation. Today, NOACs have taken the place of vitamin K antagonists. Whenever oral anticoagulation is initiated in patients with AF who is eligible for NOAC, NOAC is recommended in preference to the vitamin K antagonist because of various features we have already discussed. It's pharmacodynamic and pharmacokinetic properties, less interactions, and no need for monitoring. Antiplatelet monotherapy is not recommended for stroke prevention in AF, regardless of stroke. That is very important. So even in CHA2DS2-VASc score of 1, antiplatelet therapy, monotherapy has no role. How about AF patients undergoing PCI? Now, as you see here, we have different approaches for high ischemic risk, high bleeding risk. When people with high ischemic risk, triple therapy for 1 month and then change over to dual therapy, NOAC plus single antiplatelet agent. Whereas people with a high bleeding risk, double therapy, NOAC plus single antiplatelet agent, and after 6 months, NOAC alone. What is the dosing of NOACs in patients with the non-valvular AF? As you all know, the standard dose for rivaroxaban is 20 milligrams. And in wherever low dose is indicated, it can be reduced to 15 milligrams daily. That is, whenever the creatinine clearance is less than 50 and more than 15. Now, the classic trial which showed the utility of rivaroxaban in atrial fibrillation non-valvular AF is the ROCKET AF trial. And here, as you all know, nearly 90% of patients had a CHA2DS2 score of 2 and more than 2. That is score of 3 and 6. Thereby showing that this trial involved patients with a high risk for embolization, as opposed to the other 2 trials, RELY trial and Aristotle trial, which involved dabigatran and apixaban, which had almost equal distribution of 1, 2, and more than 2. Thereby showing that the ROCKET AF trial, which evaluated rivaroxaban, had patients with a very high stroke risk compared to other 2 trials. So as you see here, they had a higher incidence of heart failure, elderly people, that is more than 75 years, higher incident, higher proportion of diabetic patients and patients with earlier stroke and renal impairment. So AF patients studied in Rocket AF had a higher risk for stroke than patients in other trials which involved other NOACs. As you see here, the Rocket trial was a comparison between warfarin and rivaroxaban. The outcome showed 21% reduction in stroke, 15% reduction from death in mortality of any cause, and which included nearly 7,000 patients on rivaroxaban and 7,000 patients on warfarin, which is a very high population to study, with a 33% reduction in intracranial hemorrhage. So Rocket F, this nutshell, showed the superiority of rivaroxaban in preventing stroke as opposed to warfarin in patients with a high risk for stroke, namely people with a Charles-Vaz score of 3 and more. So again, in addition, it was also the secondary efficacy outcomes also showed significant improvement, which included MI and cardiovascular death. There was, as you see here, there's a 20% reduction in MI. The net clinical benefit, which includes reduction in all cause, includes the reduction in all cause mortality plus non-hemorrhagic stroke and life-threatening bleeding. As you see here, the benefit were significant in both patients above 75 and less than 75. So irrespective of age, rivaroxaban group fared better than warfarin group. Now, as you all know, prevalence of atrial fibrillation and chronic kidney disease increases with age. And every third person with atrial fibrillation has chronic kidney disease. So we have to now consider another group of patients with chronic kidney disease who require oral anticoagulation. Now, guidelines do not recommend dabigatran in patients with a creatinine clearance less than 30 ml, whereas the oxybans can be used up to 15 ml per minute. And no recommendation for NOACs in patients on hemodialysis or who have a severe end-stage renal disease with less than 15 ml per minute. So NOACs this is the only group where NOACs are contraindicated. Patients on hemodialysis and patients with a creatinine clearance of less than 15 ml. Now, we have the 3 NOACs which have been used in renal failure patients also, but most of the data comes only from Rocket trial, which has used rivaroxaban. As you see here, nearly 21% of patients who are in Rocket AF trial had moderate renal failure, as opposed to less than 2% in Aristotle and 10% in Relay trial. And in fact, the Rocket AF trial tried to also form a dose study in patients with renal impairment to find the appropriate dose. Now, in rivaroxaban, whenever you want to use it in patients with renal dysfunction, estimate the creatinine clearance. If it is more than 50 ml, use the usual dose. If it is 15 to 49, 15 milligrams, and less than 15 ml, it is not recommended. So either 20 milligrams in patients with mild renal impairment whereas anybody with 15 to 50 ml of creatinine clearance, the dose is reduced to 15 milligrams. Sorry for the interruption. Jayashree? Jayashree? Dashboard. Hello. Sorry for the interruption. I think there was some interruption.
No issue, sir. Okay, sir.
I'll do it. So as this slide shows, the risk of stroke and systemic embolization in patients with moderate renal impairment, reducing a reduced dose of Novak, it shows that it is very effective against warfarin. And 1 year outcome also shows good improvement with rivaroxaban. So reducing the Novak dose without an indication for dose reduction and against the label can increase the stroke rate without a benefit in reduction of major bleeds. That's very important. So whenever you should reduce it only when there is a definite need to reduce. So just giving a reduced dose thinking that it will avoid ischemic hemorrhagic episodes may compromise the ischemic benefit. As you see here, the utilization of Novaks against warfarin in non-valvular AF, which again, the meta-analysis of various trials show a 20% reduction in stroke, 50% reduction in intracranial hemorrhage, and 15% reduction in major bleeding, but 25% increase in GI bleeding. And not only when you use Novak, especially rivaroxaban in patients with renal failure, there is preservation of renal function. And rivaroxaban is associated with lower adverse renal outcomes compared to warfarin. As you see here, NOACs are recommended in preference to VKAs. So that's the reason why NOACs are now recommended in preference to VKAs whenever chronic anticoagulation is indicated in atrial fibrillation. So these recommendations we have already discussed. As I said earlier, antiplatelet therapy alone is not recommended for stroke prevention in atrial fibrillation. And estimated bleeding risk should not itself guide treatment decisions to use OAC for stroke prevention, unless there is absolute contraindication for oral anticoagulation. And clinical patterns, whether first detected or paroxysmal or persistent or long-standing or permanent, should not condition the indication for thromboprophylaxis, because the risk for stroke is equal in all these subgroups, whether it's a first episode or paroxysmal or persistent or permanent. Now we come to the next group of patients, patients with venous thromboembolism, the so-called venous protection. As you all know, oral anticoagulation is indicated in patients undergoing orthopedic surgery in knee and hip as a prevention for DVT and pulmonary embolism, plus also for treating DVT and pulmonary embolism. We have various studies which have shown that utility for treating venous thromboembolism. As you see here, they are as good as warfarin, and they have been shown to have a very good protective action. For dabigatran, rivaroxaban, apixaban, etoxaban, all of them show good preventive ability. Now, who is the challenging with venous thromboembolism patient? Now, fragile. 40%, 42% of patients with venous thromboembolism have a fragile constitution, and nearly 20% of them have active cancer. 20% of them have renal impairment. So, a creatinine increase of less than 50 ml, age about 70 years, body weight less than 50 kg, and very young patients, that is age between 10 to 24, they are all very high challenging cases. So as long-term anticoagulant therapy, NOACs is recommended over VKA for patients with VTE and no cancer. For VTE and cancer, the first option will be any drug which causes a low risk of bleeding and no drug-drug interaction, which includes rivaroxaban or edoxaban. So that is the approach for patients with venous thromboembolism and no cancer, and venous thromboembolism and cancer. Now let us look at the utility of rivaroxaban in the high-risk groups: fragile patients, cancer patients, young age patients, renally impaired patients. In all these patients, as you see here, rivaroxaban gives satisfying results compared to the controls. Rivaroxaban has consistent safety results also. All these fragile, cancer patients, young patients, and renal impaired patients. So thereby showing it reduces the risk and also has a safety margin. So in venous thromboembolism, rivaroxaban has been studied in a wide spectrum of challenging cases: fragile patients, renally impaired patients, patients with active cancer, and patients with a young age of less than 18. So we have a relative risk reduction of 73% whenever rivaroxaban has been used in patients with DVT bar pulmonary embolism versus enoxaparin. And in patients with recurrent venous thromboembolism, frail patients fared better than enoxaparin. So, rivaroxaban for DVT, you give 15 milligram twice a day, the total dose of 30 milligram for 21 days, followed by 20 milligram OD or 10 milligram OD, depending upon whether you have to give a low dose or not. To summarize, last 20 years, we have seen a good number of new or novel oral anticoagulants. And they have really revolutionized the treatment of chronic anticoagulation. The oxybans are factor 10A inhibitors, whereas dabigatran is a direct thrombin inhibitor. Rivaroxaban and apixaban have a low renal clearance. And rivaroxaban is the only NOAC to be approved for secondary prevention of acute coronary syndrome, chronic coronary artery disease, and chronic peripheral arterial disease. And rivaroxaban is the only NOAC to be used which has specific renal dose response is even in patients up to 15, specifically up to 15 ml, creatinine less of 15 ml per minute, where you can use a dose of rivaroxaban 15 milligram once a day. And when used in patients with renal disease, there is evidence for preservation of renal function with rivaroxaban versus warfarin, and it has been incorporated in the guidelines. And the greatest advantage of rivaroxaban is that as a single drug approach in DVT treatment, doesn't require any initial warfarin, initial heparin therapy to be followed up with oral anticoagulation. So it's a single drug approach. So straight from the day one, you can treat them with rivaroxaban. Similar thing is also with apixaban. So dear friends, I have talked to you about the utility of rivaroxaban under various situations. Most important is acute and chronic ischemic syndromes, peripheral vascular disease, then the group of non-valvular AF, and then patients with renal impairment who also require oral anticoagulation because of AF and other indications, and then venous thromboembolism, including pulmonary embolism. Thank you.
Thank you, sir. Thank you, sir. Sir, we have received 2 questions, sir. Sir, my
Yes.
voice is audible? Yes, sir. Sir, comparison of bleeding between dual antiplatelet therapy and low dose of rivaroxaban, sir. Sir, my voice is audible, sir? Ritesh, sir?
Yeah, I think sir has got some connection issue. So Muthaiya sir, you can switch on your camera also. Yeah, you can just switch on your camera also. Yeah.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Right. So I think sir is having some technical glitch.
We have to wait, sir.
Yeah. We'll just wait a couple of minutes. I think sir has logged out, so he'll just be coming and. Mutaya just received a call from sir. He might not be joining us again. I think there's some network error at his end. So you can conclude the session. Yeah.
Sir, please unmute yourself.
So, my voice is audible, sir?
Yeah, now it is
Yes,
all.
yes.
Yes, sir. Yes, sir. So it is my immense pleasure to thank one and all who are gathered here. My sincere thanks to Dr. S. Natarajan, sir. He is a senior consultant and a professor for interventional cardiologist at GKNM, Coimbatore. Thanks for wonderful speech. And thank to all delegates to giving your valuable time to on Sunday. Hopefully you are enjoyed. Thank you. Thank you.
Thank you so much. Thank you.
Thank you, sir.